A case of bilateral fracture dislocation shoulder. Now that's the case history. She's a 50-year-old lady. She's an avid trekker, presented to a senior orthopedic surgeon in my suburbs with complaints of mild pain in her left shoulder on the first day. And on asking history, she mentioned that her other shoulder, the right shoulder, also was hurting since 4 days. She started having this pain in both the shoulders after just some minor stretching maneuver. No history of trauma or any significant injury. So he got the x-rays done. Before that, he also went ahead and asked if there's any history of seizures, of any form of minor jerk. So let's go to the x-ray first. So this is what the orthopedic surgeon actually saw, sent it to me. It was a Saturday evening around 7 o'clock, and this is after the admission. I asked her, does she have any seizures history? No. Did she even at least have a minor jerk? No. Electrocution? No. Any relevant medical history? No. She just has some hypothyroidism. So this is the routine x-ray of a patient who doesn't have any of the traditional things which we know in our knowledge of shoulder that will be responsible for this sort of a magnitude of injury. So what would be the plan? Please guide us what we need to do. Should we just, it's a weekend, should we just do the close reduction? Should we do everything at one go? None of the above? So majority feel they would do close reduction followed by open reduction. Can I ask the one who clicked none of the above? Could you please elaborate why none of the above and what would you want to do then? All right. So the reason I put that was, I'll come to the reason why I put it later. I decided to do a close reduction on the same night, okay, and I didn't want to do anything major. So I usually have followed the Hippocratic method if I want to be very gentle in my reduction, so I don't cause any further damage. So we reduce the shoulder. Yeah, we're going to get a lot of chance for discussion, Raju. Many chances for discussion. Trust me.
Story has just begun.
Story has just picture abhi baki hai puri ki puri. So that's the reduction on table. Both the shoulders were reduced. I went and slept. Got the X-rays done. My registrar woke me up. And before that, further investigations would you guys like to have now, because it's just the temporary plan. So would you want to do CT scans, MRIs, or both, or any other tests? So obviously, CT scan at least was done. Sorry? Neurology wise normal. Normal. Absolutely nothing to suggest otherwise. Now, my registrar called me up when the CT scans were done, and this is what it shows. The right shoulder is reduced, GT fracture displaced. The left shoulder has dislocated again. Okay? Now what do you do? Come on, guide me.
Medical reports are okay.
Medical reports are all okay. As I told you, this is just some hormonal mild hypothyroidism, that's all. So this is the other images. So the glenoid side is okay. It's the humeral side. So one side is dislocated, one side is reduced. Further plan, investigations. What would you want to do? So she's another information, she's the daughter of a gynecologist. Sorry? Okay, so EEG for a person who's never had any history, fair enough, that's a good point to look into, because obviously something is amiss. EEG is one suggestion.
One of the worries is she having sleep seizures which are unwitnessed? Because I have seen one patient with a posterior dislocations, seizure during sleep but unwitnessed, never knew that he had epilepsy till the first presentation with a posterior dislocation, waking up in the middle of the night.
Absolutely. So how would you diagnose it? What would you do next to diagnose this problem? So Shirish mentioned EEG. What would you do?
Well, I'll call a friendly neurologist first. Well, first or whatever, because you've got a dislocated shoulder. Now you've said that on the CT the shoulder is dislocated. So you've got two things running parallel.
Exactly.
One, you have to address the shoulders, and two, you have to find out what's the underlying cause of the shoulder.
What would you do first?
Maybe a sleep study?
So Dr.
I
Very
would,
important point. What would you do first?
you have to address the shoulder. Whether she is having seizures or not, whatever the underlying pathology is, that has to be dealt with. But you can't leave a shoulder dislocated till you've got a sleep study and EEG and all the fancy tests that a neurologist is going to arrange.
So that's a great point. So we got two opinions. One, you need to look into the EEG, the neurology, and the second opinion, irrespective of what you do, you need to take care of the shoulder. I did something different because I felt something is very fishy in this. I actually got an MRI of the brain and the entire spine screened. That's the basic thing I could do. And lo and behold, this is what I see. So these are target lesions of neurocysticercosis. And you can see that cysts in the vesiculonodular stage in both the lobes. So then I started the sequence of involving a neurologist, involving an infectious disease specialist. So now what do we do next? Do we still give priority to the shoulder? Or should we, once with this diagnosis, what do you suggest?
You still have to fix the shoulder.
So the question is, she dislocated her normal shoulder and fractured it without any history. And now that we know there's a neurological problem, you have fixed the shoulder, and if similar situation happens, then you're going to have a bigger trouble. So I waited. I consulted the physicians. I waited. The infectious disease specialist was clear that anti-helminthic treatment by itself will break the cysts and cause an epilepsy episode. So what was done was the neurologist started her on anti-helminthic treatment. The infectious disease specialist started on anti-helminthic treatment. The neurologist simultaneously put her on anti-epilepsy treatment. We waited for 3 to 4 days for the acute inflammation to subside. And when we were all sure that she's under good control of anti-seizure medicines, we then went ahead with the surgical approach. So majority feel deltopectoral is needed. Deltoid split is what was suggested. Now go through the X-ray. Can we get the ARS out now?
Main presentation.
So now let's see the CT scans again. The right shoulder and the left shoulder. Would the deltoid split guys guide me? Would you do the same on the left shoulder? If yes, why? If no, why?
Why not? Deltoid split, yeah.
So it's an unstable shoulder. If there is something amiss in the glenoid side, with the deltoid split you are handicapped to take care of it, is what was going on in my mind. So I actually went with the deltopectoral approach for the right shoulder and the deltoid split approach for the left shoulder. As far as the fixation options are concerned, I think we've gone through this a lot, so let's not dwell much upon it. I guess all of us believe that hybrid fixation is a must, but still for the sake of ARS. So yes, we have discussed this, so I'll go ahead with what I actually did. So I always rely on the double row technique and the parachute technique. So the deltoid split approach on the right side and the deltopectoral approach on the left side. Now this is what it looked like. So as you can see, as expected, very porotic. So I could put some large anchors on the fracture crater and do a good double row repair. On the right side, although you see multiple screws, but I've also used a hybrid fixation. So there are tapes which are coming onto knotless anchors on the lateral side. When we followed her up with X-rays, this is what happened on the right side. So there's subsidence now. This is the time I spoke to Dr. Shirish, if he remembers. So there was subsidence on the X-rays. I was worried whether I've lost her GT. So we got her CT scans done. Things looked okay. So we went ahead with the rehab. So that's the left shoulder. She's showing some heterotropic ossification there. And the right shoulder, which is showing the subsidence of the GT. So those are her CT scans. Now this is a 2-month follow-up. She's on rehab. This is her function. There's a twist again. At 3.5 months, she had her first formal documented seizure because she was not compliant with the seizure medicines. she actually fell from the bed due to seizures. Okay, so we have all had these moments where we are scared that everything is flying off. So we called her, got her X-rays done, but fortunately, she just probably healed her tuberosity fractures. So this is what I've understood in shoulder surgery. If your fracture, if your letarge, if your bone blocks, if they have healed, then in spite of the seizure episode, then you are safe. Anybody would have done anything differently? It was okay. Yes, that's not explainable. One more surprising thing is she's a vegetarian, pure vegetarian. Yes, so she's an avid trekker. If you remember in the history I had mentioned, so when she's trekking for days together, mountaineering for days together, they don't really have access to proper food. So it is probably contaminated with the animal feces and inappropriately cooked food which she's probably had. Yes, Ramakant.
So traditionally, in the hindsight, in the first time when you reduced it, we know that there was no significant dislocation. So at the time of reduction, the joint was stable, isn't it?
Yes.
So now there is no trauma as such. So traditionally they teach that, put a transarticular KOR or something. So anybody does practice that now?
So we discussed that point very clearly. I think absolutely no. Any transarticular wires are absolutely no. We mentioned about the risk of breakage of the wire. We also should understand the risk of infection, which you are introducing directly from the skin directly into the joint. So worst case scenario, transacromiohumeral pins is what is to be recommended. Now, what I want to discuss here is there is no precedent for me when I had this case. I looked into literature. First of all, I'm dealing with a bilateral fracture dislocation, which itself is rare. She's having less pain, rare, no trauma, no seizures. So the only thing that helped me is to stick with my thought process that something is not routine. So I cannot do anything that is routine. Meaning my routine thought process is fix, I won't do it. My routine thought process is try to do everything in one go, I wouldn't do it. I would do it differently. And I was fortunate enough to pick it up on an MRI brain. Why would I ever get an MRI brain? In fact, there was resistance from the family. The mother is a gynecologist. Why do you want her to subject her to a MRI brain? I said, just let me screen, let me just have a look. And it's only because of that we picked it up. Otherwise, we would have landed up doing the procedure. She would have continued to have the seizures. And with floating implants, I would have been in a fix. So this case is all about anticipation in surgery, not about actually execution. So if you anticipate properly, then you can execute well.
Nagraj,
Yes, sir.
your post-op X-rays or AP X-rays, they look brilliant, but I would always do orthogonal X-rays
Yes,
from post-op.
Absolutely.
And I find that instead of the axial, the striker notch view gives a much better understanding of how the GT has healed.
Sure. So fortunately, we were doing CT scans also continuously, so we were documenting that. So three-dimensional imaging was available. And she's been in follow-up for very long now. She's really happy. She's gone back to her mountaineering. She sends pictures from Ladakh. She's been to Egypt and stuff. So this was operated on the 25th of December. So she calls me her Santa Claus. And so the take-home message is think out of the box for these rare presentations, involve the physician neurologist. So another important point is I involved an infectious disease specialist. Otherwise, how would we understand what is the nature of the schizons after we start the antihelminthic treatment? So it is only through their guidance that I could wait for those few days and then go ahead and fix it up. Use the double row concept, that is a hybrid fixation. I'm happy to discuss further or any questions.
Sir, did you do the MRI and not find a Bankart in this case?
So I think it's overrated. If it's a primary dislocation in a 50-year-old, what would I do? I would conserve, right? So I think it's overrated. The only reason I went deltopectoral on the left shoulder was because she was so unstable. So I'm worried of a rim fracture, which is missed out. So in a situation where on table, if I find that everything is very unstable, then I wouldn't hesitate to go ahead and do whatever needs to be done on the glenoid side.
So with this, we come to the end of the session. I'll request Dr. Milin to give a token of honor to Dr. Nagraj. So next, so I would like to invite all the speakers on the stage for group photograph of this session.